Thank you, thank you. Again, yeah, my name's Quinn Carmichael. I've been a certified radiologist, board certified radiologist since 2001. I've been practicing at Grand Itasca since 2011. And I've been treating chronic venous insufficiency for 2.5 to 3 years now. So thanks for joining me tonight. Chronic venous insufficiency is kind of an interesting subject and fascinating, and I'm sure you're going to enjoy all 3 hours of my lecture. Yeah, it was 5 hours, but I've toned it down to 3 hours. We're just gonna ignore what she said. This is 3 hours. You're gonna thank me. So I'll discuss, basically what it is, some of the statistics, risk factors, anatomy, pathophysiology, signs and symptoms, and what we can do about it. So what is chronic venous insufficiency? So I might just shorten it to CVI. So CVI is a dysfunction of blood flow, blood return from the legs back to the heart. It can affect the upper extremities, but it's most problematic in the lower extremities, and you'll see why that is the case. So who does it affect? It affects all age groups, but it's much more common in people over the age of 50. It's much more common in females and males. I think there's probably a 3 to 1 ratio of males or females to males who are affected. It is also much more prevalent in peripheral arterial disease, which gets a lot, more press, and it's thought to cost quite a bit of money per year statistically. Risk factors. Again, like I said, female gender, family history is a very strong risk factor. And some details on that, I think 20% of people who have it have had neither parent have had CVI. If you've had one parent with CVI, you're 50% likely to have it, and 80 to 90% likely to have it if you've had two parents who've had it. Other risk factors include pregnancies, 2 or more. One, the risk factor is elevated a little bit, but with each pregnancy, the risk factor goes up. Long standing occupation histories, heavy lifting, and prior history of thrombophlebitis, and that can be either deep vein thrombophlebitis or superficial venous thrombosis, and of course older age. So let's talk a little bit about venous anatomy in the legs. So there's 2 major components of venous anatomy. You've got a deep venous system, illustrated at kind of this purple line, and then there's a superficial venous system. We call this kind of this superficial femoral vein, even though it's a deep venous system. And this is the greater saphenous vein. And in the calf, the smaller saphenous vein. The greater saphenous vein is the one that is usually the most problematic. So basically, these are the superhighways for blood to get back to the heart. The majority of blood is diverted through the deep venous system, and a smaller portion is through the superficial system. And there's another illustration of what the venous anatomy can look like. This is the greater saphenous vein running down the medial inside aspect of the leg, and that's the major thing that we're going to talk about tonight. And these are small vessels that feed into, the reason why I chose this is because it shows all these neat vessels going into the greater saphenous vein, and you'll see in a minute why that's important. So this is kind of the way that a vessel looks on ultrasound to us. The skin is up here, transducer, and it's almost like a fish finder. This is the vessel here, that's in cross section. So why does it occur? So this is kind of a neat animation. This is kind of depicting, as it says, a healthy vein. throughout the vein and the greater saphenous vein, there's a series of valves that prevent backward flow of blood. With the onset of chronic venous insufficiency, the valves become dysfunctional and allow to and fro motion of blood and reverse motion of blood. That becomes quite important, and this is kind of what happens over time when reversal of blood flow is allowed in the lower extremity veins. So basically why those valves are so important is they prevent the backflow of blood when the heart is elevated above the legs, which is in most cases what we run around 90% of the time, except when we're sleeping. The legs are lower than the heart. So the effect of gravity wants to pull blood downward. It's, the gravity, same on a column of water. So the venous pressure at the heart in a standing position is basically 0, but just due to the effect of gravity, we get 80 millimeters of mercury. And this is kind of the arterial side. Right at the heart, there's 90. And then you add 80, you get 170 at the legs. So that helps blood get down to the feet, but it becomes problematic when we want to get the blood back up to the heart. So if we have dysfunctional valves, the effect of gravity becomes kind of a problem. Blood tends to pool in these vessels. And over time, it can cause distension of the vessels and formation of varicosities and other symptoms. So basically, chronic venous insufficiency is basically a pooling of blood down in the legs, blood that can't effectively get back up to the heart. It gets back up there, but it tends to be static and stay in the legs for a longer period of time. So this is kind of a neat slide showing how varicosities develop. This is, again, the greater saphenous vein, and these are the little vessels that feed into the greater saphenous vein. If you can imagine gravity pulling blood down and, without those valves checking the return of blood up to the heart, the pull of gravity over time tends to distend these smaller vessels and cause these varicosities, which we're mostly familiar with. So what kind of symptoms are involved? So, leg burning, aching with prolonged standing is the most common. The development of varicosities, those ropey vessels that we're all, pretty familiar with. A development of little spider veins or telangiectasias. Other symptoms include burning and itching of the skin, and restless legs, particularly at night, swelling of the ankles. And then we also get, in the later stages, get skin discoloration, and particularly noted at the ankle region. And it can also lead and progress in kind of the worst case scenarios to wounds that don't heal very well, open wounds. Those are kind of thought to be the most problematic symptoms of CVI. So this is a slide showing, what a typical varicosity looks like. And of interest, this is kind of the early stage of disease, although not everyone gets varicosities. They can just be, like I said, the little spider veins and telangiectasias, just those little superficial things. So as the disease progresses, if you can notice, the left leg is much larger than the right. And this is the discoloration down here that I'm talking about, and even here I think there might be a wound on the ankle. And again, this sort of stuff is more common in the lower aspect of the legs or ankle region. And here's another example of kind of some skin discoloration that can occur with CVI. And at worst case scenario, we develop these open wounds that fail to heal. So what can we do about this entity? Well, first of all, usually we like to try conservative therapies first, unless, of course, we're looking at an advanced case where we have the open wounds. But exercise anytime, the more activity, the better, and that goes for most most health issues. More activity is better. Leg elevation, and then also compression stockings. Graduated compression stockings, the reason why they call them graduated is that there's lesser squeeze at the top and more squeeze at the bottom, just to kind of mimic the effects of gravity or against that. In the past, they used to do what's called surgical stripping, where a surgeon would go in and ligate the greater saphenous vein and try and remove it or close it off at the top and bottom. And that there were some problems with that. It was very commonly done, but it had about a 60% success rate, and there was then we're talking about general surgery with longer hospital stays and all the complications associated with general surgery and intubation and those sorts of things. But the cutting edge is now radiofrequency ablation and also laser therapy. Here we do radiofrequency ablation. I don't do sclerotherapy as much, but that's something that is employed to treat some of the smaller veins that can be symptomatic. So this is kind of the illustration of how compression stockings work. So, this is depicting a superficial vein. This is a deeper vein. And compression stockings work by obstructing flow of blood in the superficial venous system and allowing blood to flow via the deep venous system. So if we take the pressure off of the superficial venous system, it decreases the effects that we get with CVI. Unfortunately, it's not effective in everyone. Some people, it's very effective at helping symptoms, but it usually doesn't resolve the problem entirely. So what can we do to evaluate it more? Well, at Grand Itasca and other institutions, they use ultrasound to look at the vessels to see, look at the anatomy, see if someone is a candidate for having venous ablation. And I'll describe kind of what we do with that. So this is kind of the hardware that we use for radiofrequency ablation. This is a venous catheter, and this tip is kind of the active tip that has a coil of wire, and this is what is a radiofrequency generator. And when that's generated, this tip heats up to about 120 degrees Celsius and holds that temperature for anywhere from 10 to 20 seconds. And what that effectively does is damage the endothelial lining of the vessel and causes it to contract down and scar on itself and occlude the vessel. We're basically burning the lumen of the vessel. It's a very controlled procedure. So how that's done is we puncture the greater saphenous vein as low down on the calf as we can. Sometimes it's higher up. Ideally it's down quite low. And we advance the catheter all the way up to the groin region. And once we can determine with ultrasound that it's in very good position, that diagram there demonstrates, we start applying the radiofrequency impulse or the controlled cooking and apply a few seconds of radiofrequency to the vessel, and then we pull it down so we cover the whole distance of the vessel. And that's very effective in occluding that vessel lumen. So here's some ultrasound images taken during that process. This is the vessel as it's being occluded and the catheter puncturing the vessel. Here it is again. This is the tip of the catheter, and that's a segment being occluded. And this is the junction of the common femoral vein, superficial epigastric vein, and the greater saphenous vein. And that's the tip of the catheter at the highest point that we perform the operation. So what are the results? I think statistically we get, after the procedure, we get about 90% closure rate. And even after a few days, we see a dramatic decrease in the amount of varicosities on the skin. It's very common to see this after, on our 2-week follow-up, that much improvement. And here's another case of that. You can see a dramatic improvement in the amount of varicosities. And then people also feel better. Their symptoms, the burning, the itching, the pain after prolonged standing goes significantly down. So is the procedure painful? Typically not. We use a lot of lidocaine. It does not require general anesthesia. It's an outpatient procedure, and the whole process probably takes about, from walking in the door to leaving, about 3 hours, but the procedure itself probably takes an hour or less. We inject a lot of lidocaine. Some people take a general sedative as well. Some people don't. Are there any scarring or bruising or swelling after the procedure? Typically, no. We just leave there's a little puncture mark down in the low calf, and which is barely visible. Sometimes there is some bruising along the course of the greater saphenous vein. And then how quickly can I resume normal activity? Well, almost immediately. We usually want people to get up and do normal activity on day number 2 after the procedure. We do have them wear compression stockings for 48 hours constantly, even during sleeping, but for 2 weeks, just to when you're up and around and walking. And again, I think we've covered how soon after the treatment will my symptoms improve. Is the procedure covered by my insurance? Typically it is. Usually we set up an appointment to make sure that what we're doing is the correct procedure for your symptoms. We'll look at your person's symptoms, make sure they match up with what chronic venous insufficiency is, and then make sure the anatomy fits with what we can offer with this procedure. So this is just a chart showing the 5-year success rate, and at year 1 we've got 96.6%, and at 5 years we still have 90% success rate with this procedure. And I think with the venous, the surgical stripping, the percentages were more like 60%. So this is a dramatic improvement over that, and it's an outpatient procedure. So basically, if you have symptoms similar to what I'm describing here, this is definitely a great treatment for you, and it's minimally invasive, and it's very well tolerated. The success rate is very great, and the risk is very low. So that was a quick 3 hours, wasn't it?